Well, tonight it's my pleasure to welcome you to a webinar entitled Management of Abnormal Uterine Bleeding in the Primary Care Setting. It is presented by Dr. Jade James. Dr. James is an obstetrician gynecologist in St. Louis, Missouri. She received her undergraduate degree from Fisk University in Nashville. While attending Fisk, she became a joint scholar with the Fisk-Meharry Joint Biomedical Sciences Program and thus received her medical degree from Meharry. Later, she completed a surgical internship at the State University of New York at Buffalo and then completed her residency in obstetrics and gynecology at at Jamaica Hospital in Queens, New York. Later, she completed her Master's of Public Health in May 2012. So congratulations, that's very, very recent. She's the current chair of the Department of OBGYN at SSM DePaul Healthcare in St. Louis and president for Mound City Medical Forum, the Missouri State Society for the National Medical Association. She is a member of ACOG, the National Medical Association, and Delta Sigma Theta sorority. She is the proud mother of a daughter, Gabrielle. Approval for CME credit has been filed with the American Academy of Family Physicians and is approved for 1 hour. Questions and comments can be submitted throughout the presentation. To submit a question to the presenter, please type the question and/or comment in the Q&A box found at the lower left-hand corner of your screen and click Submit. In addition, there will be a question and answer session at the end of our presentation. So, ladies and gentlemen, with all of that said, please join me in welcoming Dr. Jade James.
Good evening, everybody. Thank you for joining us. It is my pleasure to present to you management of abnormal uterine bleeding in the primary care setting. Based on the answers that you all have given to the poll, most of you all are metropolitan providers or urban providers. At least half of you manage abnormal uterine bleeding on a weekly basis, and at least one person admitted that they were uncomfortable treating abnormal uterine bleeding. So I hope that we have something for everybody. And as Ms. Jackson said, if you have any questions, then please, by all means, go ahead and ask your question at the time so that you don't get lost in the presentation as we go through. So my disclosure statement, I do not have any financial or other relationships with the manufacturers of any commercial services discussed in this particular educational activity. For the objectives today, we're going to talk a little bit about understanding normal menstrual bleeding, and then we're going to define abnormal menstrual bleeding. We're going to talk about the management for the primary care provider, and then we're going to talk about when you should actually refer a patient for abnormal menstrual bleeding. For the purposes of this discussion, we're going to kind of group together abnormal menstrual bleeding, abnormal vaginal bleeding. We're going to suffice it to say that we do need to differentiate between vaginal and uterine bleeding, but this discussion is not going to make that differentiation for you. So we're going to make the assumption that we've gone through the process of differentiating between vaginal bleeding and uterine bleeding. So if you have questions related to vaginal bleeding, I can answer them, but that's not going to be the focus of today's discussion. So initially...
Real quick, Dr. James.
Sure.
Could you move the mic in front of your mouth? Okay, is that better? That's better.
Okay. So we're going to talk about the normal menstrual cycle, and without taking you back to first year med school physiology, we're going to make it very simple, and we're going to say that the normal menstrual cycle is broken into 3 phases. You have your follicular phase, which is estrogen dependent, you have your ovulation, and then you have your luteal phase. So your follicular phase is when you have your follicular development. It is estrogen dependent, and it typically lasts 10 to 14 days. Now, this is based on an average average 28-day cycle, but we know that while 75 to 80% of people will have a normal cycle, that means the other 25 to 30% can actually fall outside of that normal 28 to 35-day cycle. Ovulation actually occurs, and that's the phase that's associated with your LH surge, and that occurs about 10 to 12 hours after your actual LH surge. There are commercial LH kits available, or ovulation kits, to try to detect that LH surge for those people that are trying to actually time for fertility reasons. But for the sake of this discussion, ovulation is just the phase associated with your LH surge, and that occurs, ovulation occurs in and of itself 10 to 12 hours after that. For your luteal phase, that is primarily progesterone dependent, and then estrogen comes in towards the end, but that's the phase that's associated with your corpus luteum. You have formation of the corpus luteum, you have your peak progesterone and estradiol levels, and the luteal phase itself takes about 8 to 9 days. So if your cycle is a normal cycle, it's sort of a nice even circle where you have your estrogen, your endometrial proliferation, your follicular development, your ovulation, your progesterone. The progesterone, once you get the surge of progesterone, you get a interruption of your endometrial growth, and you actually promote differentiation, and that leads to the regression of your corpus luteum. Your progesterone levels fall and your endometrial sheds. It's that shedding of the endometrium that gives you your menstrual flow. And then that cycle starts all over again. And so if all of those phases are in order, what you end up with is a cyclic pattern that's typically predictable. You have specific intervals between cycles, or a constant interval between cycles. You have a constant duration of flow, and you typically have a constant volume of flow. And this gives us a nice, neat little 28 to 35-day cycle that we like to call the menstrual cycle. So with that, when any part of that process is interrupted, we call that abnormal uterine bleeding or an abnormal menstrual cycle. And there have been multiple definitions associated with abnormal uterine bleeding. And so some of them include menorrhagia, which is prolonged or excessive uterine bleeding at regular intervals, the loss of 80 milliliters or more of blood per menstrual cycle, or the bleeding that lasts for more than 7 days. And typically you can get patients that give you either of these descriptions, and so I listed all of the definitions. For menorrhagia, you have irregular menstrual bleeding, or you have bleeding between periods. For polymenorrhea, that just simply means frequent menstrual bleeding. More strictly or clinically, it can be referred to as menstrual bleeding that occurs every 21 days or less. And then for menomenorrhagia, it's a combination of menorrhagia and metorrhagia. So you have frequent bleeding that is excessive and irregular in both the amount and the duration. Another way to sort of clinically define abnormal uterine bleeding is in a premenopausal woman. It's just simply a substantial change in frequency, duration, or amount of bleeding during or between periods. And for the postmenopausal woman, abnormal bleeding is any vaginal bleeding 1 year after cessation of menses. These are what I would call clinical definitions, but they actually work very well. If you go back one slide and you look, do you really know whether the loss is 80 milliliters or more? Do you really, what if it's 75? Do you not investigate it? What if the bleeding lasts, 4 days, but they're using, a 28 pack of pads every day just in that 4-day time frame? Is that not considered abnormal? So with all of those vague sort of what ifs, you can always go with the clinical definition. If she's premenopausal, if she's had what she considers a substantial change in frequency, duration, or amount during or between her periods, then it deserves investigation. And any postmenopausal woman, any vaginal bleeding 1 year after the cessation of menses is considered abnormal. In your postmenopausal age category, you have to make sure that they actually have not stopped, that they've actually stopped their menses for a full year, because when they're in that perimenopausal period, a number of them will actually stop for 6 or 7 months. and then they'll have a cycle, and then they'll say, oh, it's been a year. And then if you dig a little bit deeper into their history, you realize, no, it's actually been about 6 months. And so it's not quite considered abnormal because they would be in that perimenopausal as opposed to postmenopausal range. In terms of classifying abnormal uterine bleeding, I found at least 4 different ways to classify it. And what I want to say is that I don't think it really matters how you classify the abnormal uterine bleeding. Most of these classifications are done for workup purposes. And so for some people, it's easier for them to understand ovulatory, anovulatory, and anatomic. For some people, they prefer to divide it into functional or dysfunctional. And then there's also premenopausal, perimenopausal, and postmenopausal. And then you have physiologic and pathologic. And the reason these different clinical classifications have come about is because it gives the clinician sort of a guide in terms of how to rule in or rule out what may be the problem. I don't think that it's important that you know all of them. I think what's easiest is that you pick one that works for you, because all of the classifications will actually get you, or should get you, to the same workup. And then come to a general conclusion. So it doesn't matter which classification you use, just as long as you use one to kind of help you give a consistent clinical workup picture. So when we look at the differential diagnosis, we have what ACOG puts in their differential diagnosis versus what American Academy of Family Physicians puts in their diagnosis. And the lists are pretty much the same. With the ACOG list, of course, there are a few other what we would call GYN complaints that get added to the differential list. But I think for the primary care physician, I think the American Academy of Family Physician list is actually adequate, because those things that are added to the ACOG list probably would not be taken care of by most primary care physicians. If you found one of those things, such as endometrial polyps or fibroids, you would likely refer those to the GYN anyway. And even if you were to find the endometrial polyps or the leiomyomas or the fibroids, they would actually be considered your benign pelvic pathology, which is a category listed on the American Academy of Family Physician differential list. And so, again, I don't think that it matters which list that you select from, but if you have sort of an idea of the general categories for your differential diagnosis, it can give you a systematic way of what to try to rule in or rule out as you consider a patient with abnormal uterine bleeding. So we have this patient who comes in with a complaint of a significant change in menstrual bleeding, whether it's amount, duration, or any of that. And so what are we going to do for this patient? So it's definitely important to take a detailed history, and your physical exam is going to give you clues. And you know, one of the things that you're going to do, so you're going to find out the frequency, you're going to find out the duration, you're going to find out what's considered a normal menstrual pattern for them. You also want to find out about their medical and or family history. For example, diabetes, thyroid disease, history of any endocrinopathy in the family may clue you in as to whether or not you should be looking for an endocrinopathy in this particular patient. In terms of a physical exam, you definitely want to have the BMI as part of your differential. And then don't forget about simple clues to your physical exam. For example, if a patient has significant abnormal uterine bleeding, they probably should have pale conjunctiva because they'd be anemic. And so if they had, it's not to say that if their conjunctiva are not pale, it's not to say that they're not anemic or they may not have abnormal uterine bleeding, but in those patients that give you sort of a sketchy history, you can certainly use that as an additional piece of information to try to give you a clinical picture when the history is a little bit scant. You want to locate the bleeding. You want to see if it's vaginal bleeding, uterine bleeding, or cervical bleeding, because that does matter. You want to find out what medications that they may be taking. I do have on another slide, we're going to look at some of the medications that are implicated in abnormal uterine bleeding. And then you want to go with whichever classification system that you use. You want to try to get an idea of whether it's ovulatory or anovulatory cycle, or if you think that there's an anatomic problem, like maybe endometrial polyps or maybe even a fibroid. And those clues will actually come from your physical exam. Other parts of your physical exam, although it's uterine bleeding, you don't want to forget the simple parts of the physical exam, like looking for goiters or features of hirsutism, to make you think of maybe a systemic medical condition as opposed to true abnormal uterine bleeding. When we talk about the lab values, we want to make sure everybody with abnormal uterine bleeding needs to have pregnancy ruled out. And so whether you do that with a urine HCG or whether you do that with a beta HCG just depends on your clinical capabilities where you practice. And almost always, you want to get a CBC, one, to kind of help guide you clinically in terms of how fast you need to correct their anemia. And then the other labs, and we'll get to some of them, but other labs at that point are going to be dictated by what you find in your history and physical. So if you have a strong suspicion of thyroid disease, then you want to add a TSH. If they have features of hirsutism, you may be looking at some endocrine labs like DHEA, or maybe even a testosterone level. So you want to make sure that you get a good history and physical, because that's going to guide your laboratory workup. So in terms of your evaluation, here's where sometimes the classifications may help you if you want to categorize them as premenopausal, perimenopausal, and postmenopausal. But in your age groups, typically, if you have an adolescent with abnormal uterine bleeding and you've ruled out pregnancy, the next thing that you really want to look at is a coagulation profile. Von Willebrand's is the most common coagulopathy that presents actually with abnormal menstrual bleeding. And so because it is so common in the adolescent population, that's the next best test after you've done your pregnancy test and your CBC. You want to look at your coagulation profile. Again, based on your history and physical, you may or may not do prolactin levels, your thyroid levels, your FSH, your LH. And then the reason I have an endometrial biopsy on here for the adolescent population is because chronic anovulation, which is abnormal uterine bleeding, and it essentially is the equivalent of unopposed estrogen. So if you have your obese adolescents that come in and they've had these menstrual irregularities for 2 to 3 years, they may actually qualify for an endometrial biopsy, even though they're not greater than 35, because they've now had 2 to 3 years of chronic anovulation, which is the equivalent of a 35-year-old with unopposed estrogen. So no, every adolescent that comes in doesn't need an endometrial biopsy, but certainly if you're dealing with an obese adolescent female, or if you've dealt with this female for a number of years and you still haven't been able to quite get control of this abnormal bleeding, then you can consider an endometrial biopsy even in an adolescent. If we move on to the reproductive age group, then we want to start thinking, number one, we want to rule out anatomic causes. And then also, based on your history, you want to look at your TSH level, your FSH level, your LH level, your testosterone. And then in the reproductive age group, if you are greater than 35 with abnormal menstrual bleeding, an endometrial biopsy is, again, almost always indicated. So for your reproductive age group, you're going to have a lot more endometrial biopsies than your adolescent. And then in your postmenopausal women, your evaluation is going to include an ultrasound to look at anatomic causes, and the number one being endometrial polyps. But then you also want some sort of endometrial evaluation. There are some people that are still doing office endometrial biopsies, which is fine. There are some people that actually, depending on where you're practicing and what you do, will actually still take these women for an actual DNC. And then we now have the added advantage of either a sonohistogram or some sort of endometrial evaluation with a combination of radiologic modalities. Now, if you are one of those people that like to rule in or rule out, or like to use the ovulatory and ovulatory classification, then here's one way to do it. If you have unpredictable cycle length, unpredictable bleeding, unpredictable spotting, unpredictable heavy bleeding, and just kind of if you have someone that actually keeps their temperature curve and it's just sort of a flat line, those people are likely anovulatory because there's no predictable pattern. It's just unpredictable for the most part. Whereas your ovulatory patients, they generally will have regular cycles. A lot of them will actually get premenstrual syndrome. They will get your typical ovulatory symptoms. They may have your middle smirks, which is sort of that pelvic pain in the middle of the cycle, which we think is pain at the time of ovulation. So I have one person that asks a question. In the adolescent patients, what are we looking for with an endometrial biopsy? If you have an adolescent patient with chronic anovulation, they are in the category of unexposed estrogen, and so they are just as at risk for endometrial cancer as the older population with chronic anovulation or chronic unopposed estrogen exposure. And so in your adolescent patient, if you have been dealing with them for 5 or more years and you still have this sort of anovulatory unpredictable pattern, they actually are at risk for endometrial cancer because they've had 3 to 5 years of unopposed estrogen essentially. So and that's why not every adolescent needs an endometrial biopsy, but there are some that may actually qualify for it. And so, well, the risk in adolescence is not that high until you start adding on the number of years that that they've had this sort of unopposed estrogen pattern, which is what we call chronic anovulation. And so that's what starts to put them at a greater risk even though they are young. So when we start to look at treatment, if we go back and we look at those different categories, and for the purposes of this webinar, I'm going to use the American Academy of Family Physicians. I'm going to use that differential diagnosis scheme. And so if you look back at that scheme, the first category was complications of pregnancy. So again, we said in our evaluation, we're going to rule out pregnancy first. So they come in, the complaint is abnormal bleeding. We do a pregnancy test, and the pregnancy test comes back positive. So with a positive pregnancy test, then we want to look at whether or not that pregnancy is intrauterine pregnancy or an extrauterine pregnancy, such as an ectopic or a gestational trophoblastic disease. If the pregnancy is in fact intrauterine, if you are a primary care provider that handles low risk abortions low risk pregnancies, or that deals with failed pregnancies in the early gestation, if it's a spontaneous abortion, then you would just kind of follow them with ultrasounds to make sure that the uterus has been completely evacuated. If you're comfortable with following that process, you can actually continue to follow that process. And so that's what I consider treat them. So you would treat the spontaneous abortion. And if you are in a setting where you're not comfortable with that, then at that point you would actually refer to a GYN, preferably directly to a GYN physician, but at the very least you would send that patient to the emergency room for further evaluation and treatment. If in fact it is an intrauterine pregnancy, but you suspect placenta previa, you're going to refer that person to the OB. Now, truthfully, in the early part of the gestation, you won't really know that it's a placenta previa. So if you are a provider that deals with low-risk pregnancies and you discover sort of mid-pregnancy that this is placenta previa, that is a case where you would actually refer them to the OB, unless you are in a truly rural setting where the family practice physicians kind of serve as the obstetrician as well, and they just consult with either the obstetrician or a high-risk specialist. And then if the pregnancy is extrauterine, then you certainly want to refer to an OB or GYN provider to manage the extrauterine pregnancy, or if it's GTD is for gestational trophoblastic disease. Now, the second category on that differential diagnosis was infections. If you've taken the history physical from this patient, you've ruled out pregnancy, and part of your physical exam, you notice infections. Well, if you discover an infection, it needs to be treated. If it's a sexually transmitted infection, then you treat it appropriately. Cervicitis, you can either treat, a lot of ER physicians can actually treat cervicitis, but of course, if at any point you're uncomfortable with treating any of these infections, then you would certainly refer them to your GYN or one of your partners or something of that nature. But you definitely want to rule out infections as well. And the most common ones are sexually transmitted infections, cervicitis, endometritis, and let's not forget urinary tract infections can also give you kind of that spotting, and people just assume it's all from the same place. You don't want to forget about trauma. As part of your physical exam, most traumas can actually be ruled out. You want to look to see if there are any lacerations, and you want to look for both internal and external lacerations. You want to look and see if there's any abrasions, or you want to look for any foreign body. And the foreign body can be in any age group. Certainly with small children, you want to consider toys. But even with reproductive age adults, I have found condoms that have remained. I have found an old tampon that they thought had been removed, and it sort of just wedged itself in the back. So there are a number of foreign bodies that find their way in the vagina, and so when they don't come out, they start to create spotting. And the other thing with the foreign body is that if you remove a foreign body, you want to go ahead and check, because sometimes the foreign body itself will actually build up sort of a subsequent infection like cervicitis or endometritis. So you want to make sure that if you actually find a foreign body, you want to treat the check for infection and treat that as well. Malignant neoplasms. It doesn't matter which one you find. If you find it, that is no longer a primary care condition. And so this arrow here shows us that if you find a malignant neoplasm, it should go straight to your local GYN physician. Or even your not so local if you're in, or even your not so local if you are if you're in sort of a rural area and you have to refer. But certainly any malignant neoplasm needs to be referred to GYN, or preferably actually an oncologist. Your benign pathology category, that's your leiomyoma, which is your fibroid. Your adenomyosis. Sometimes you have clues about adenomyosis. Really, adenomyosis is sort of a retrospective diagnosis, because you really don't get an actual diagnosis until you have a specimen to send to pathology and to get that as a pathologic diagnosis. And then your endometrial polyps. But if you suspect any of these things, or if your ultrasound shows you that these are the cause of your problem, then those are things that you want to refer to your GYN, with the exception maybe of the polyps. The reason I say that is that some people are skilled with office hysteroscopy, and some of the smaller polyps can actually be removed with office hysteroscopy. So if you have the ability to do that, you can. Just make sure that you send your polyp for pathological diagnosis. Most polyps are benign. I think it's 1% or maybe even less than 1% may actually be associated with cancer. So you definitely want to send those to pathology for actual diagnosis. And then you have your systemic diseases like your coagulopathy, your thrombocytopenia, your renal disease, your hepatic disease, and your leukemias. All of these will actually require further evaluation. And in these particular instances, you actually do not want to focus or attempt to treat the vaginal bleeding or the menstrual bleeding. You actually want to treat the systemic disease, and as the systemic disease is corrected, then you will actually get correction of your abnormal menstrual bleeding or your abnormal uterine bleeding. And so these are a little specific. These are condition specific. So again, your coagulopathy, you're going to evaluate these based on your suspicion of what these, if you fall into one of these categories. In terms of treatment, we talked earlier when you want to take your history and physical, you want to have an idea of medications, because there are some medications that have been implicated as a cause for abnormal bleeding. Certainly anticoagulants can do it. Acetocyclic acid, which is aspirin. You want to find out if your patients are on antidepressants. Your antidepressants like your SSRI, so that's your Paxil, that's your Prozac, your tricyclic antidepressants. So if they're on antidepressants, you really want to find out which one, because a number of them are implicated in vaginal bleeding. Hormone replacement therapy. Sometimes when you begin patients on hormone replacement therapy, especially if they maintain their uterus, you have to give them combined hormone replacement therapy. And so initially when you place them on it, they may actually have some menstrual bleeding, similar to a menstrual cycle in the early phases of starting the hormone replacement. And so when you start women on hormone replacement therapy, you have to actually counsel them that this is a possibility. Patients on tamoxifen, if you've had a patient with previous history of breast cancer, or even the inherited breast cancer syndromes, and they're using tamoxifen for prophylaxis. Tamoxifen is an estrogen receptor modulator, and so it can actually stimulate the uterus and create vaginal bleeding. Phenodiazines, corticosteroids, thyroxine, contraceptives can also do it. And then you want to definitely ask them about their natural history. You have a lot of naturalists, people that are into just sort of naturally treating certain conditions. So you want to find out if they're taking any kind of soy products. Soy products are heavy in estrogen. If they're taking ginkgo biloba or ginseng, all of those have been implicated in abnormal bleeding. So with the treatment, if you are one of those people who like to put things into sort of your anatomic, ovulatory, and anovulatory categories, once you determine that it's ovulatory bleeding, you want to try to get to the, if you can get to the cause, that's fine. But even if you never get down to the actual cause, you ruled out that it's not anovulatory, you ruled out that it's not anatomic, you have several options for treatment. In the primary care setting, you certainly have your oral contraceptive pills, you have your NSAIDs, and you have your antifibrinolytics. And I have ablation on here as a therapy. In the primary care setting, I'm not sure that even if you are certified or skilled to do office hysteroscopy, I'm not sure that that you're qualified for the ablation. So if you are, certainly by all means you would go ahead with the ablation as an option. And then if your ablation is or if it's not ablation, then you would just refer that to the GYN. I got a little started there. I see someone has a question that says, what's the mechanism of action for the antidepressants? I'm not sure about the actual mechanism for the antidepressants. I can try to look at that for you here in a second, but it actually has to do with your feedback pathway, and so I will look that up and get a better answer for you in a little bit. Oh, I'm sorry. One other thing with your ovulatory, although we put on here oral contraceptive pills, I have actually used the vaginal ring as a combination contraceptive. And before the patch got a lot of bad publicity and a bad rap, you could actually even use the patch if the patient is appropriately counseled. So just because it says oral contraceptive pills, you're not necessarily obligated for just the pills. If you're looking for a combination method, you can use any of the FDA approved combination contraceptive methods. If you've determined in your evaluation that the patient has anovulatory bleeding, then there are several options for anovulatory bleeding. Again, you have your contraceptives. This says oral contraceptives, but contraceptives. Your progesterone IUD is actually a excellent choice for anovulatory bleeding. I generally try to get an idea from my patients, a contraceptive history or a family planning history. Try to find out if they are even remotely interested in children within the next 5 years. Kind of what's your family planning plan? Because if certainly you want to get your cycles regulated so that you can immediately start trying, then I'm not sure that the progesterone IUD is the right option for you. And so the progesterone IUD is the Mirena. For ovulatory bleeding, if your cycles are regular, one of the reasons that the progesterone IUD is not, it depends on the patient desire. You can use the Mirena for ovulatory bleeding, but those people are then going to become amenorrheic. And so you have some people that believe not having a period is not normal. So you kind of have to know what patient you're dealing with in terms of using the Mirena for ovulatory bleeding. If amenorrhea is one of their desires, though you cannot guarantee it, you can certainly use the Mirena. But because it's a progesterone, because it's a single hormone method, it usually doesn't end up on the list for ovulatory bleeding, because most ovulatory bleeding, you want to keep that balance between estrogen and progesterone so that they can go back to a regular cycle. So your anovulatory bleeding, cyclic progestins can be done. If you are doing GnRH agonists or androgens, you should either be really, really good with using those, or you should kind of reserve those for the reproductive endocrinologist, partly because they are still laden with heavy side effects. And if you're not familiar with those medications, these patients need a lot of reassurance and a lot of counseling in regards to the side effects. Also, again, depending on whether your patient is adolescent, reproductive age for your anovulatory bleeding. So yes, they are on the list of treatments for anovulatory, but if you're not comfortable with those medications, then I would caution, I would certainly try the contraceptives, the progesterone IUD or the cyclic progesterones before I went with the androgens or the GnRH agonist. There's a question: what would you recommend for anovulatory bleeding in an adolescent who does not desire hormones for religious reasons? That's a good question. In an adolescent who does not desire hormones, sometimes I think what we explain to our patients, I think the language is different. I have gotten away from using the word contraceptive in patients that have those religious convictions, because I explain to the parents that hormones are natural and that they're a natural part of the body, but for whatever reason that internal hormonal balance is off, and so we need to use outside hormones to balance that scale. I find that when you start to call them hormones more than you call them contraceptives, then you have better reception. And when you explain to people why you're using hormones and you take out the additional contraceptive benefit, but just explain that you're trying to balance out their hormones, most of them will tend to actually go ahead with that. If they are still not receptive to that, then I would probably, if you're not comfortable using the androgens or the GnRH agonists, I would probably refer them to someone that is, because those are not, those are not direct hormone related. Essentially, all of these are in that hormone cycle. And so if their real issue is contraception, then I become very clear that we're not using this for contraception, although that's a side benefit. And I kind of say that's a side benefit very low. If I say it at all, I just say we're using the hormones in here to balance out the hormones that you have that aren't in the proper alignment. So when do you refer? In terms of referring, So if you are an inexperienced physician, inexperienced means you just don't want to deal with it. You don't like to deal with it. You're not comfortable dealing with it. If you're not, comfortable with abnormal uterine bleeding, it is certainly acceptable to refer the patient. If advanced evaluation is required, such as those endometrial evaluations, if you think the patient can benefit from the sonohysterography because your ultrasound machine is down and you know that there's a local GYN office that does the sonohysterography, certainly you can get that endometrial evaluation through that. If hysteroscopy is required and you're not certified to do the hysteroscopy, then you would make that referral. If DNC is required, as that is still a surgical procedure, we don't use it as much as we used to, but it's still there and it's still available. Some other reasons that you may refer is when the initial treatment doesn't work. Whenever you encounter malignancy, you want to get an oncologist involved sooner rather than later. And then when you do find a diagnosis and surgical treatment is necessary, so you find that leiomyoma and she says, I'm done having kids, I want it out, you want to go ahead and refer to your GYN doctor. And so these are my references. I want to thank you guys for your time. I want to thank you for listening to me, and we are open for other questions. Try the cream once, then start it. Okay, hold on. I see a couple of questions coming in. The first one says, I put a postmenopausal patient on topical estrogen for atrophic vaginitis. She tried the cream once, then started spotting the next day. Is this common? She hadn't taken the progesterone component yet. If she had atrophic vaginitis, the vaginitis can sometimes be an irritant in and of itself. You can see spotting. I don't know if common is the right word for it. We've seen it before. I don't really know how common. We don't necessarily see it in everybody. So, but what you tell her is just to continue to use the topical estrogen, because what happens is that you have to get enough substance to revive the vagina, so to speak, so that it's not so atrophic and it's not so irritating. So she can definitely continue the topical estrogen, and then she would just continue on the regimen that you initially prescribed for her. The next question is, I have tried Paragard for those non-hormonal wanting sorry, lost the question. I've tried Paragard for those non-hormonal wanting patient, and some have worked. Any thoughts on this? You can try the Paragard. What the patient insert for the Paragard says is that it will not alter your menstrual cycle. And so for some women, if they have talked to older women about Paragard has, in some sectors, it has a bad name for creating vaginal bleeding. That has not been my personal experience. So I think that you can use Paragard for the longer contraceptive benefit, especially in that, say, 35-year-old patient who definitely, says, I'm done having kids. I don't care if I have a period again, but I'm not really ready, or I'm not qualified for surgery. Certainly, I think Paragard is a viable option because you get, 10 years of contraceptive benefit. And if you're one of those women that fall in that, the average age of menopause is actually 51. And so if you're 35, that'll at least get you to 45 with both contraceptive, and hopefully your cycles will go to whatever its regular pattern is. So yes, I've known some people to use Paragard, but if you look at the literature and if you look at the recommendations, it doesn't list Paragard on that. Sabrina, I think this question is for you. It says, this is my first webinar. Will the PowerPoint be available for further review?
Yes, we can. I can
Uh,
actually send you a PDF copy of the slides. And at
okay.
the end, I'll put my email address in a little box so you can have it. Just email me and I'll PDF. I'll do a PDF and send it to you.
Okay. The next question that I see is that should most women undergo endometrial biopsy to be on the safe side? Um, I think the first thing that you have to do is categorize the female based on the age. And then, um, so if we go back to the slide we had, oh, here it goes. So if it's an adolescent, I think the answer is typically no, but I don't want people to forget about that adolescent that has been obese and has had chronic anovulation problems. Say you started seeing this adolescent at 13 and by 19, she's even more obese than she was at 13 and she's had these off and on menstrual problems. Some of it may be related to compliant to whether or not she's compliant with with the contraceptives or the hormonal pills, and some of it may be that she's just not regulating well. Those are the patients that I don't want you to forget to at least consider, or even offer an endometrial biopsy. When you get to your reproductive age group, you really have to put sort of a clinical picture together. So I don't know that I could really advocate everybody undergoing endometrial biopsy just to be on the safe side. I think that with the availability of the ultrasound and the other imaging modalities for the uterus, in addition to the availability of hysteroscopy, I think a diagnostic hysteroscopy may or may not be better than just a blanket endometrial biopsy for everybody. So I think just to take the question at face value, should most women undergo endometrial biopsy to be on the safe side? All postmenopausal women should undergo some sort of endometrial evaluation, which can be an endometrial biopsy or DNC or whatever. But when you get to that reproductive and that adolescent age group, you certainly have to you make some general assumptions, but I don't know that I would agree that most women should undergo endometrial biopsy. And I'm not sure how cost effective that is either. Are there any additional questions? I want to make sure I didn't forget anybody.
There may be some more coming in.
Yeah, that's
Give them
I'm just going back and making sure that I didn't skip any.
Give them a little bit of time to type. I do have a question. Is there any reason why ultrasound would not be in the initial workup for the adolescent?
Because honestly, with the adolescent, they're more likely to have a coagulopathy if they, especially if they present at the actual age of menarche with just a heavy first period. I want to say it's something like 30 to 40% of those young ladies will actually have a coagulopathy. And so it's so prevalent that it's actually the coagulation profile that's recommended before you start any other workup. Also, with the adolescent patient, if you ruled out pregnancy and if you've done the coagulation profile, you can actually start those young ladies on an oral contraceptive for a 3 to 6 month trial to see if they regulate. And if they don't regulate, then you want to actually go to the ultrasound and the rest of the workup.
That was going to be part of my
Um,
follow-up. Like, how long do you allow them? I know some adolescents, when they initially start at menarche, they are irregular. But how long do you give them before you, okay, say this is, how long do you give them to regulate? Do you give them the first year, the first year and a
Um,
half?
a lot of people now, it used to be said you give them 3 to 6 months. A number of people have actually extended that to at least a year. And then the biggest thing with adolescents is that you have to almost keep retaking a history on the adolescents. One of the biggest issues is that you'll start them on, say, some contraceptive method, some hormonal method, and then they'll get regular, and then they'll either get busy with school activities, sports, or whatever, and they'll stop taking it, or they'll just stop taking it, like, oh, I'm regular now, I don't need it anymore. So the biggest thing you have to do with adolescents is you have to go back and revisit it. Are they actually compliant? And if they actually are compliant and then they're still irregular, it depends on how much of a problem it is for them. Some people, you can reassure them and you can say, okay, let's do this, let's give it a year. And then some women are so, anxious, some that we like to, oftentimes call hypochondriacs. But some people are just way too anxious, and by 3 months, they're driving you up the wall, because they want something done different. They don't want to keep going through this. And so typically I would say a minimum of 6 months, but you can do it at least a year before you start looking into other investigations. And then the other thing is that once you start them on that contraceptive method, you have already looked at, their coagulation profile. I actually, in my own practice, I tend to probably do more TSHs than not. I've probably found maybe 4 cases of thyroid abnormalities that have been relatively subtle but have presented themselves as abnormal menstrual bleeding. So I will actually tend to do my thyroid profile with my initial workup. I rule out the pregnancy, and then I do my TSH and my CBC actually together. And we have a couple of more questions. I had a patient who was on OCPs for 10 years. She started having lengthy breakthrough bleeding after taking phentermine for weight loss, it looks like. Would changing her OCPs to ones with higher dose of estrogen be a treatment option? So she was on OCPs for a very long time. And then all of a sudden she started having breakthrough bleeding with her weight loss. If she's been on OCPs for 10 years, I would try to get an idea of what her long-term family planning, what's her long-term family planning, if she has one. If she's been on OCPs for 10 years, and she's starting to have this sort of breakthrough bleeding, I would actually try to see if she was a candidate for an IUD, and probably the progesterone only IUD. It gives you contraception. It can fit into a family planning regimen. Um, and It may solve the issue. With the weight loss, a lot of times we tell obese patients, if you lose just a minimum of 10% of your body weight, you start to get some of the reversal of all of this heavy bleeding. So I don't know if I don't know the mechanism of action of phentermine enough to know if it's interfering um, with her menstrual cycle. I think that was on my list of medications. Let me go back and look. Um, but I would look at no, it was actually phenothiazines. It wasn't phentermine. So I would look at the mechanism of action, and that's one where I would look to see if phentermine is sort of implicated in this whole process. And then the other thing is, if she's taken the phentermine, how much weight has she lost, and how much longer is she going to be on it, if there's an interaction with the phentermine and her ability to control her cycle. So there's a couple of different questions. I'm not a huge advocate of going back to higher doses of the estrogen, mainly because the higher doses of estrogen are the ones that were implicated in your unopposed estrogen, in your risks for endometrial cancer and things like that. And that's why we started going to the lower doses. The other option would be to look at some of your other pills. Low estrogen 24 gives you more coverage, and it reports less breakthrough bleeding. And so one of the options may be to just switch the pill and to try the low estrogen 24 in particular, because it has a different coverage range than the other OCPs.
These were awesome questions.
Yes, they
I'm
were.
not
Thank you guys
not
for
sure if there are
participating.
any I'm not sure if there are any more coming, but for those of you who'd like to have a PDF of the slides, you can email me at sajackson@msm.edu. I'm trying to type it out to put it on an announcement to come up. It'll come out in a minute, but it's sajackson@msm for Morehouse School of Medicine.edu, and just put in the subject line requests of the PowerPoint, and we'll take care of it. Dr. James, I would like to say thank you so much for sharing your expertise. Your method of presentation was very, very good. This was, I don't know that it's such a simple topic, but you explained it in a very easily understood way, so we appreciate that. Ladies and gentlemen, Dr. James is actually going to be back to join us next month for a maternal child health coffee shop. And right now we think we're going to entitle it probably Hot Topics. We'll discuss probably a few things, but elective inductions is one. We will probably discuss the new PAP guidelines, the screening guidelines, and I was also thinking that maybe we'll talk a little bit about contraception and some of the issues with, you're always hearing in the news that some birth control pill is killing someone. So maybe we'll talk about that too, oral contraceptives and the controversies that surround them. So just it's going to be on the fourth Thursday of July, and I think we said that date was July 26th, was it?
24th, I think it is. Hold on, wait. I'm
Okay,
gonna look
24th
real
or
quick for
26th.
you.
But you guys can just check the
24th,
calendar.
July 24th.
Yeah, so it'll be entitled Hot Topics, that we know for sure. So make sure you bring your questions. We do have want to highlight a few things that's coming up for the remainder of this month. This month we're only having 2 webinars. So the next webinar will not be next Wednesday, but 2 weeks. It'll be June 27th, I think it is, and it's on health disparities for people with disabilities. So we want you to come out for that. Next Tuesday is the mid-level coffee shop. We'll be discussing precepting. And you don't have to be a mid-level to join the discussion, but we have someone who's the director of a program, and she'll be doing a presentation on what makes a good preceptor, how to know when you're ready, what kind of experience you need to have, and just kind of raise our awareness to know the necessity of being a good preceptor. So please come out and join us for that next Tuesday. The last Thursday of the month, so every month, the 4th week, we typically have 3 events. So we'll have the maternal child health coffee shop, which this month we'll be discussing high risk OB. Then on that Wednesday is a webinar, and then on Thursday is the primary care coffee shop. And we'll be talking about the Affordable Care Act and what that looks like in the primary care setting and in community health. So, but you guys can check the calendar on the website for all of those things. I know it's a lot to think about. So again, Dr. James, thank you so much for this insightful presentation tonight. Again, this series is made possible through a partnership. The partnership allows us here at PrimaryCareForAll.org to serve as a resource for the National Health Service Corps. Direct financial support is made possible through a cooperative agreement with the U.S. Department of Health and Human Services, Health Resources and Services Administration, and the Bureau of Clinician Recruitment and Services. The webinar was recorded and it will be available in the on-demand section of the site. PDFs of the slides can be obtained by emailing me at sajackson@msm.edu. Please remember to visit the website to see our resource section, to look at our blogs, and to read the forum. As we close, finally, please take a few moments to complete the evaluation for this webinar. It'll pop up in another window if you're using IE and another tab if you're using Firefox. Please complete it in its entirety to obtain your 1-hour CE credit through AAFP. Thanks again to our IT/e-learning specialist, Mr. Quallen Hare. As usual,
Yes,
I could not do this without you. So thank you, everyone, and have a great evening.